All right, hi everybody. My name is Ben Travers. I'm a second-year medical student at Oakland University William Beaumont School of Medicine, and today I'm going to be talking about a new trauma protocol for assessing geriatric patients in the emergency department. So, as people get older, they're more likely to suffer from an intracranial hemorrhage, and the risk of death after a hemorrhage is significantly increased if patients are taking blood thinners. Now, the problem is there's a small subset of patients who present after an intracranial hemorrhage with nonspecific symptoms. And so this poses a challenge to emergency medicine physicians in how to handle patients who are presenting in the ED after a fall who might not have the classic symptoms of an intracranial hemorrhage. Now, the solution to this problem that was devised by our hospital was to create a new trauma protocol called the Level 3 Trauma Protocol. And what this protocol entailed was upgrading all patients who were older than 65 and taking blood thinners and were presenting to the ED after a fall to the Level 3 trauma activation. And this meant that these patients would be immediately seen by an ED physician and a nurse, and it would allow the physician to evaluate the patient and determine if the patient needed to go to CT, and if at this point in time the patient needed to be activated to a level 2 or a level 1 trauma. And so this prevented the over-activation of the trauma team. So the objectives of our study were to assess the effectiveness of the level 3 trauma protocol. We wanted to see if this protocol is actually worthwhile by determining the incidence of intracranial hemorrhages in patients triaged by the protocol. We wanted to assess its resource utilization as well as its efficiency, and we wanted to determine if it led to better health outcomes for patients. So our methodology was a retrospective cohort chart review type study. And so we went back into the charts of patients to assess the effectiveness of the level 3 trauma protocol. We included patients in this study if they met the level 3 trauma protocol criteria, meaning we included patients if they were older than 65 and taking blood thinners. We also wanted to focus on patients with an intracranial bleed, so we only included patients who had a positive CT for an intracranial hemorrhage. And we also wanted to only include patients who were not initially triaged by a level 1 or level 2 trauma protocol. This meant that we were including patients who were initially triaged by the level 3 trauma protocol or not triaged by any protocol. And so when we went to review charts, we wanted to divide patients into two groups. We had a group of patients who were not triaged by the level 3 trauma protocol because it wasn't established at that time. And this was our pre-level 3 trauma group. These patients would have been triaged by the level 3 trauma protocol, but it wasn't established at that time. And so we were comparing these patients to the patients who were triaged by the level 3 trauma protocol. And that was our post-level 3 trauma group. And we had 12 patients in our pre-level 3 trauma group and 56 patients in our post-level 3 trauma group. And so we went back in the charts to assess 4 variables about health outcomes. And so we included variables such as the time from arrival in the ED to CT, as well as the ED length of stay, the hospital length of stay, 1-month mortality, 6-month mortality, etc. And we used t-tests and chi-square tests for our statistical analysis. So what we found was approximately 11.4% of the patients who were triaged by the level 3 trauma protocol had an intracranial bleed, which meant we were picking up a significant portion of patients who otherwise would have potentially received delayed treatment. We also found a significant decrease in the time from arrival to CT and the ED length of stay for patients who were triaged by this protocol. And we can see that visually in the graph on the left side of the screen here. On the x-axis, we're looking at time from arrival to CT, as well as the ED length of stay. And on the y-axis, we're looking at time in hours. The blue bars are referring to our pre-level 3 trauma group, and the yellow bars are referring to our post-level 3 trauma group. And you can see that there's a significant reduction in time, both from arrival to CT as well as the ED length of stay. Now, we didn't find any significant difference in health outcomes between the pre and post level 3 trauma groups. So what can we take away from this study? What we can take away that the level 3 trauma protocol is worthwhile because a significant portion of patients who are triaged by this protocol actually had an intracranial bleed. And so that meant we were preventing these patients from potentially receiving delayed treatment because we were able to pick up that they had an intracranial bleed. We can also say that this protocol reduces resource overutilization. So the level 3 trauma protocol means that an ED physician and a nurse will see the patient right away. And this is in contrast to activating the trauma team, which would include the trauma surgeon and the ED physician, as well as nurses, EKG tech, X-ray tech, and all of this in a resuscitation room. And so what the level 3 trauma protocol allows us to do is prevent that overactivation on all patients. And instead, it allows the ED physician to decide whether or not the trauma team should be activated later on, but rather than having it activated right away. Now, the level trauma 3 protocol also improves the efficiency, and we can see this in improving the time to diagnosis by having patients make it to CT faster, as well as shortening the overall stay that patients are spending in the emergency department. Lastly, the level 3 trauma protocol doesn't lead to a change in patient health outcomes. Now, we can say that there's a shorter time diagnosis, which means treatment begins sooner, and we're giving patients the best opportunity for a positive outcome. And so even though the level 3 trauma protocol isn't leading to a significant difference in health outcomes, it is giving patients the best opportunity for success. And so lastly, I want to thank everyone who helped out with this project. It was a team effort, and everyone put in a lot of work, and it helped to get a very successful project. So thank you.